listening to Praveen and then Manoj Chopra. Very interesting. And today I'll be talking to you on the use of imaging in instant restenosis and stent failures, that is stent thrombosis. See, in whatever we have been doing so many PCIs, and whatever you do, by 5 years, it's almost 15 to 16% of deaths. There is a stent failure. There's a lesion failure, and it requires something to be done for that. And today in US, almost 10% of PCIs are for ISR, that is for stent failure. See, very important is in treatment of ISR, the accurate diagnosis definitely alters the treatment. So we have so many options from plain balloon, drug-eluting balloon, and then we have bacterotherapy. Today we have laser, everything. How to make a decision regarding the therapy available now. And coming to imaging, imaging is class 2A indication today as of the ESA guidelines. And probably for ISR, I think it should be updated shortly. It's an example here. This is a patient who had an LAD stented almost some 3-4 years back. He comes back with acute anterior wall MI in the same territory. So there was a biovascular scaffold which was put almost 5 years back there in that LAD. 3 years, that is post BVS. 3 years later, he comes back with this anterior wall MI. And he lands up in the middle of the night. And in the middle of the night, I have just done a thrombosection there. And once I do the thrombosection, this is the angiogram that you get here. And look at this angiogram here. BVS is here for the last 2.5 to 3 years back. And this is the lesion. Plain thrombosection gives such a good result. So basically what to do now? Should we do anything or just leave this patient? Because if you see that there is not much of stenosis and then there is a good T3 flow. So with this patient was the middle of the night. That day we didn't do anything, but later we took him up for the OCT imaging. Look at this OCT. What you get is there is a relatively homogeneous intimal cover, but there are many places where there is no endothelization at all. So it is almost 2.5 to 3 years post BVS. There was no endothelization and struts were all hanging there, and minimal neointimal hyperplasia. And most of the hyperplasia was homogeneous. It is not heterogeneous neointimal hyperplasia, what you get in BVSs. So anyhow, this patient was definitely borderline lesion on angiogram. But I did a FFR, which was really positive in the LAD, so there was no option. We had to treat it. So by the time I planned, so the lesion was quite long, and so I have put a big drug-eluting stent with excellent expansion there and with good results. And you see that stent being deployed here with excellent result there. And basically, ISR is one of the reasons for stent thrombosis. And uncovered struts are one of the very important reasons for acute stent thrombosis. So here, imaging clearly showed that there were hanging struts which were not covered. And then definitely instant restenosis appeared. This FFR was also positive, which helped us in taking the decision for PCI. And this patient here underwent and primary PCI in the one day. One day later, he again has ST elevation in the same segment. And he had something here. So what happened when you do an angiogram, we really don't know what is the reason for this stent thrombosis within 24 hours. So on imaging, when I did a OCT, there is a clear area of malopposition. Generally, malopposition is not very dangerous compared to underexpansion. But this patient had a stent thrombosis within 24 hours after a plasty. Plasty was done in the middle of the night for as a primary angioplasty and reinfarction. And angio showed nothing. But when you do an OCT, you clearly know what is the reason for that. And this was simply treated with the post-dilatation balloon and then with excellent result there. And this is a very interesting case, was treated by one of my friends there. He had this patient was stented for an non-QMI, probably in the circumflex area as a culprit vessel. He also had a reinfarction in that area almost around 10 to 12 hours after the procedure. So he took up the patient and he did a thrombosection there and he took an angiogram. He really did not know what was the reason for this stent thrombosis. Since the patient was a VIP, he sent him to me to know what is the reason. So I did a OCT here. Look at this. Angio clearly shows nothing. You feel that it's a good, well-deployed stent with good TIMI3 flow there. But when you do an OCT there, it gives the reason for a stent thrombosis. See, there is a very major dissection at the distal part, which you cannot pick up on the angio. And then there are areas of malapposition and areas of underexpansion. So this is a multiple reason that patient has a major dissection, shear compromising the lumen, and the malapposition and underexpansion. All this caused stent thrombosis. So he was treated with another stent there. I covered the distal dissection and with an excellent results. So basically in stent thrombosis, the common reasons are basically if there is a malapposition, significant malapposition, stent underexpansion, edge dissections, and of course, if you land in a plaque, which is more than 50% plaque burden, and neoatherosclerosis. These are the very important reasons for stent thrombosis. Angiographically, you cannot just diagnose this. OCT gives a clear idea what is the reason for the stent failure, and you can take a decision. Coming to ISR again, the causes for restenosis are instant for very important is landing in a plaque, which is more than 50% plaque burden, and presence of thrombus, and stent underexpansion is one of the important reasons. And of course, stent fractures and then stent edge dissections. These are some of the reasons for instant restenosis. Even after 6 months, it can be early, late, anytime. This restenosis, these are the important reasons. And to make out that imaging is very, very useful. And upfront, if you use an imaging, many times you can reduce the instant failure or stent failures at itself. And coming to therapy, very important is today we have different options, starting from drug-coated balloons to drug-eluting stents, ELCA, IVL, and DES. Just on angiogram, it is very difficult to decide what is the best treatment for this patient. So, for example, this is the flow chart here. If there is a disease at the edge of the stent, there is no doubt at all. He requires a stent, drug-eluting stent there. In the ISR, which is inside the stent body itself, we have different options. If it is a homogeneous in-stent restenosis, many times you can get away with a drug-eluting balloon itself. But if it's a heterogeneous, calcified, very lipid-rich, such cases, probably you require a drug-eluting stent again. And calcium-rich, probably IVL, or you need a rota cutting balloon. So many options are needed in taking a decision for that. And this is the image of homogeneous where it is very clear. This is heterogeneous and layered one. Yeah. Somebody's mic is on. Can you just mute? Can others mute, please? Yeah. This is a case here. A case of homogeneous ISR here. See, this patient had a clear instant restenosis, which is at the body of the stent here. It is at the body of the stent here. And the edges of the stents are fine. And when you do an imaging, it is a very clear, homogeneous appearance of that ISR. It's a drug-eluting stent, but sometimes even in DES, you can get such a homogeneous instant restenosis. So this patient, what I did is I prepared this lesion there and then just put a drug-eluting balloon and just caught away like this, which is an excellent result. And follow-up also, his patient is very fine. You look at the other parts of the stent here, there is exact good neointimal coverage here. Only at this point, probably there was a little bit of underexpansion, which has given rise to this instant restenosis at this area. So this underexpansion plus that growth was treated with cutting balloon, scoring balloon, and just treated with a drug-eluting balloon with very good results. Another example, an ISR in the proximal LAD here, very critical stenosis. And here you see here, it is a multi-layered heterogeneous ISR which has occurred there. So in such a patient, what is important is you should prepare the lesion very well so that you get a good lumen area, lumen expansion, and it's a heterogeneous ingrowth there. So what I have done is I have used different balloons. I have used a cutting balloon, scoring balloon, and of course NCs to know that it is an adequate prepared lesion before I take a new stent there. So very important is you make sure that you don't leave any tissue behind, or you should have adequate lumen gain before you take a new stent there. Otherwise, what happens is you will just create a sandwich. There will be tissue in between the two layers of the stent. To make out this, you just cannot make out in an angiogram. It's impossible to know that whether you have prepared it very well and what is the distance between the old stent and the new stent. OCT clearly shows that, and this is the impact of preparation, what I have done there with excellent expansion. When you look at the OCT run here also, you can make out that it is well expanded there, and then our preparation is very adequate, and that's the time to take a next stent, and then I've deployed there with excellent result. And there is no, look at this, there is no sandwich, and both the layers of stents are overlapped with good expansion there. And this is the final result where you see a excellent expansion with two layers of the stents almost nearby there. Coming to this very latest update, Light Lab study is a very important study where they have compared the impact of OCT in therapy. In ISR group also, there is a subset which has been analyzed. See, they have found out that almost 25% of ISR cannot be made out in an angiogram, and 50% OCT added clear mechanism of ISR than compared to angiogram in this study. This Light Lab initiative is from US. We also did a similar study called IOPTICO study in India, and which has also given similar results. But here, it is an ISR subset analysis. And the impact of vessel preparation strategy. In ISR, almost 73% of the vessel preparation was changed when OCT was done. They used a lot of cutting balloons. They used a lot of atherectomies or lasers to achieve initial lumen gain before they put a new stent. So it is very important. It makes a great impact in your therapy and long-term results. And number of stents implanted also comes down in ISR because when you know the etiology of ISR, you need not stent all cases, because predominantly they decided on non-stenting strategies like just dilating the lesion or just using a drug-eluting balloon, which is always better for the patient. And coming to stent expansion, compared to only on average angiogram, they achieved almost 73-77% average initial stent expansion was good with OCT. And minimum stent area, which they achieved, was very, very significant, 72% increase in the stent area compared to angiogram. So this is the impact it produces on treatment of ISR. To conclude, what we say is, if at all available or if possible, for all stent failures, OCT is very, very important. And it changes in almost 91% of cases compared to angiogram, especially ISR, when you use OCT pre and post. And you get excellent stent expansions. And of course, preparation strategy also changes in most of the cases. And I think with this, I'll stop here. Thank you very much for the listening.
Thank you, Selvamani, for your showing us the importance of OCT in ISR, and also the importance of OCT in detecting the thrombus and the malpositions and other defects of stents.